Human beings are complicated. You don't need a doctor to tell you that. But if we look at the incredible systems that have to be balanced for our bodies to keep them going, and we look at how we treat our bodies sometimes, it's a wonder that they work at all. It would be easy to think of the body as a collection of individual organs, and it would be easy to believe that if you had a problem in one organ, it would remain in that one part of the body. But that's just not how it works. Let's take the example of a car for an analogy. If you have trouble with the brakes issue is not going to affect the engine, the transmission, the air conditioner, or the paint job. But that's not how the human body works. The individual organs are connected in this intricate way that is dynamic. And if you have something wrong with your heart, for example, it can affect your lungs, your brain, your kidneys, and just about everything else. Sometimes diseases crop up in two or more different organs and interact with each other. When a person has two independent problems going on in their body, the term that doctors use is comorbidity. Those multiple problems affect the same organ sometimes, or they may be in two different parts of the body. So you could have two problems with your heart, or one problem with your heart and one problem with your hip. All of that is called comorbidity. So why does any of this matter? For a few reasons. Number one, if there are problems that routinely crop up together, the person taking care of the patient really needs to know about them. For example, if people have sleep apnea, they often also have high blood pressure, so it's important for the doctor to check the blood pressure when they're seeing people with sleep apnea. Number two, if people have a comorbid illness that is undetected, it can make it difficult to restore that individual to function. For example, if a heart patient also has asthma, how are they going to participate in cardiac rehabilitation exercises when they can't breathe? If you don't know about both problems, then you can't really make much progress with either of them. Today we're going to look at comorbidities in mental health. Today you're going to come across a long list of conditions that occur in the background when someone comes in for their main problem. We're going to cover a lot of ground, and there is no expectation that you're going to become an expert in diagnosing any of these conditions. However, if you're aware of them, then you can be a lot more supportive of your veterans as they seek care and try to improve their mental health. In this case, knowledge really is power. If we think about fear as a natural response to a threat, then anxiety is fear gone haywire. The anxious person reports fear when there is no threat, or they have an exaggerated fear response from a minor threat. What's also typical about anxiety disorders is a need to flee. People with anxiety literally go out of their way to avoid things that could make them more anxious. Let's look at a few of these conditions. One condition that some consider an anxiety disorder is PTSD. We're not going to spend any additional time on PTSD as that condition has an entire module devoted to it. Panic disorder. Panic disorder is a pretty common condition, as 2 to 3% of all people in the United States are diagnosed with it. There's a pretty big overlap between panic disorder and depression. There's also another big overlap between panic disorder and problem drinking, as people with panic sometimes use alcohol to help themselves calm down. In order to be diagnosed with panic disorder, a person must have panic attacks and a persistent fear of having more panic attacks. Panic attacks are sudden episodes of anxiety that include intense symptoms such as pounding heartbeat, chest pain, sweating, tremor, shortness of breath, nausea, numbness, or tingling. Generalized anxiety disorder. This is another common anxiety disorder, and about 3% of the general population has this problem. Unlike panic disorder, where the individual experiences sudden episodes of anxiety that hit them like a truck, the person with generalized anxiety disorder experiences chronic and persistent anxiety that happens more days than not. Their anxious feelings could include restlessness, becoming easily tired, difficulty with concentration, irritability, muscle tension, and problems with sleep. There's a big overlap between this condition and depression as well. Social anxiety disorder, formerly called social phobia. This is one of the most common mental disorders, and it's present in about 7% of the US population. It starts in childhood and persists into adulthood. People with social anxiety experience an intense fear around social situations, and they constantly fear that they're being judged by others. As a result, they do their best to avoid social interactions, meeting new people, being watched by others, or public speaking. They have an intense fear of embarrassment. There's a big overlap between this condition and other anxiety disorders. There's also big overlap between this condition, depression, and substance use. Specific phobias. These are so common that we don't often think of them as mental disorders. About 7 to 9% of the US population experiences some sort of irrational fear of a specific object or situation. Fear of heights, fear of certain animals, fear of needles are pretty common examples. These phobias kind of stand on their own, and people with phobias often don't go to the doctor for treatment. Obsessive compulsive disorder. Now this one's a bit different than the other anxiety disorders that we've talked about so far. This condition involves the presence of obsessions, compulsions, or both. Obsessions are persistent thoughts that are intrusive and disturbing to the person experiencing them. Compulsions are repetitive behaviors that the individual feels required to do by their obsession. A common example of this condition would be an obsession that the person's hands are dirty and the compulsion to wash them repeatedly. People with obsessive compulsive disorder usually realize the irrationality of their actions, but they feel afraid to stop. This description brings up a good point. Sometimes people will use terms in everyday language that are actually used very differently by the mental health community. Think about how you might have used the term obsessive when describing somebody and see if it fits with the diagnosis of obsessive compulsive disorder. Now, I'm not saying that we can't use the word obsessive in our regular language, but when we're talking about this stuff, it's a good idea to be precise. And in terms of overlap, obsessive compulsive disorder overlaps quite a bit with depression and other anxiety disorders. There's a real difference between feeling anxious sometimes and being diagnosed with an anxiety disorder. It's a matter of severity, dysfunction, and persistence. The same goes for mood disorders. Major depressive disorder is different than feeling the blues for a few days. People with major depression experience at least 2 weeks of overwhelmingly low mood. Their low mood is accompanied by some of the following symptoms: decreased interest in activities that they used to enjoy, erratic appetite with significant weight loss or weight gain, erratic sleep with either insomnia or sleeping too much, fatigue, poor concentration, and possible thoughts of death or suicide. About 7% of the US population is currently experiencing symptoms of depression, making this a major public health issue. It's more common in women than in men. And as we talked about earlier, there's a pretty big overlap between major depression and many anxiety disorders. There's also a big overlap between major depression and substance use. Some people experience changes in their mood that switch between depressive episodes just like those in major depressive disorder and some sort of other mood state that seems to be the opposite of depression. We're now talking about bipolar disorder. This other mood state that's the opposite of depression is called mania and consists of elevated mood or intense irritability. Manic moods must be associated with some of the following features: inflated self-esteem or feeling like you're better than everybody else, decreased need for sleep and not feeling tired the next morning, rapid speech, racing thoughts, easy distractibility, increased activity, and increased risk-taking behavior. It's important to understand that this condition, which affects 1 to 2% of the population, is not the same as having frequent mood swings. Manic episodes must last for several uninterrupted days at a time. And I think it's important because popular culture overuses the term bipolar to mean something else. I think sometimes the term is used to mean rapid mood swings or irrational behavior. I'd advise caution now that you know the true meaning of the term bipolar disorder. This condition is very serious and carries a suicide risk that is 15 times higher than the general population. Fully 25% of all completed suicides can be linked to a diagnosis of bipolar disorder. These individuals almost always have other mental disorders as well, including anxiety disorders, attention deficit hyperactivity disorder, and substance use disorders. There isn't a single symptom of schizophrenia that is diagnostic for this condition. The Latin word for schizophrenia translates to split mind. And sometimes I think Hollywood believes that schizophrenia is some sort of multiple personality disorder. In fact, there's nothing about schizophrenia that has anything to do with multiple personality disorder. Schizophrenia is the most severe mental disorder, and it involves a cluster of changes to thinking, emotions, and behavior that can be severely disabling. The most obvious symptoms of schizophrenia are the so-called positive symptoms. These include fixed false beliefs called delusions, the experience of hearing or seeing things that other people cannot, those are called hallucinations, and disorganization of speech so that others can't really follow their train of thought when they're talking. Now, the delusions often have a paranoid quality to them, so the person feels as if they're being hunted or persecuted. The hallucinations are usually auditory, and they sound like voices outside the person's head. The voices can be very critical, loud, and difficult to ignore. Sometimes people with schizophrenia can be seen talking back to these voices to try to get them to shut up, or at least say something nice. The other cluster of symptoms that people with schizophrenia may experience are the so-called negative symptoms. Negative symptoms of schizophrenia include a flat or almost robotic emotional range, decreased activity, and decreased attention to hygiene. This terrible condition affects about 1% of the US population and usually starts in the late teen years or early 20s. It can have a dramatic beginning, which is called a psychotic break. There may or may not be a trigger to the psychotic break, but the trigger could involve exposure to a great deal of stress. Because of the age of onset of this condition, it's possible for the psychotic break to occur early in military service among young service members. Tobacco use and other substance use is quite common in people diagnosed with schizophrenia. Life expectancy is shorter than the average person, probably because people with schizophrenia have difficulty engaging in behaviors that promote health. I'd like to briefly mention a related condition called schizoaffective disorder. You might see that term in a veteran's records and wonder, is this different than schizophrenia? Schizoaffective disorder is a version of schizophrenia. These individuals have all the features of schizophrenia and they experience frequent clinical depression or even manic episodes. So schizoaffective disorder is like schizophrenia with major depression or bipolar disorder layered on top. Obviously, this is a serious condition and needs to be treated by qualified professionals.